I really appreciate you. You are the hardy ones, because after yesterday's introduction, I wasn't sure anybody would come. So I'm excited to see you here. Though I really wish those of you in the back would come a little bit closer. We don't bite. Hopefully many of you now know my name. I'm Al Farrow. I'm a Senior Director of Clinical Affairs at the Foundation, and I've been very, very fortunate to be part of our lung transplant initiative. And my co-speaker is Erin Tallarico. She is our Director of the Lung Transplant Initiative. She comes to us from Johns Hopkins, where she was a CF nurse coordinator, and prior to that, she was actually a transplant coordinator, not lungs. She did kidney and pancreas. And then prior to that, she worked in an organ procurement organization. So she has all this insight about transplant and CF. So we were very, very lucky to be able to steal her from Hopkins, and they haven't forgiven me yet. So what we hope to do today is go more in depth from what we did yesterday. Yesterday was really sort of, the typical 10 countries, 7 days through Europe kind of thing. So we hope that we can slow it down a little bit and still leave time for questions today. So provide you some background about the Lung Transplant Initiative, why we felt there was a need for this, and where we've been focusing our efforts and where we are now. So how did we get here? And it really started with a comprehensive strategic planning initiative that the Foundation had some 5-6 years ago, where it emerged that lung transplantation was clearly an area of need. And then we were hearing loud and clear from the CF community that this was something that was important to our community. Many people, even though it's in the back of their minds, we've heard from many adults with CF that this is something they think about. It doesn't matter what their FEV1 is, they do think about lung transplantation. And then clearly for those of our community who have developed advanced lung disease and are facing this decision and trying to determine if it's the right decision for them, needing more resources and more information. And quite honestly, the disconnect between CF care programs and transplant programs, they really are different worlds. We all know this. And so the difficulty, the frustrations associated with trying to navigate those waters to go from a CF program to a transplant program. So we heard all this, and in 2016, actually it was March of 2016, a lung transplant summit was held in Bethesda. So I hadn't joined the foundation yet, but Joe Paluski, who I mentioned yesterday, adult CF and transplant pulmonologist at the University of Pittsburgh, helped guide the foundation in terms of who to invite to the summit. And the purpose of the summit was really to provide the foundation with a roadmap as how to proceed in this new lung transplant world that we were entering. And that led, I was hired then obviously to join the foundation and help lead this initiative and provide oversight from the foundation's part. And in that spring, we announced the multi-year $15 million investment into the lung transplant initiative. And then the question really was, well, where are we going to allocate this money and what are we going to do? So Joe and I kind of started to get to work on this. And one of the areas that clearly was in need was beyond the peer support, the educational support, the emotional support that we wanted to provide people with CF, was the fact that there was a window for improvement here. So what you see here is what's called Kaplan Meier survival curve. But what I really just want for you to really see is that in purple, you see people with cystic fibrosis. And then the other colors represent other diagnoses that have led to lung transplantation. And being higher, so the purple being on top of these other curves, represents the fact that people with CF actually do better after transplant than any other diagnosis that leads to transplant, which is really remarkable when you think about the fact that people with CF tend to be infected in their airways. So the 5-year survival or the median survival being where 50% of people who've had a transplant are still alive after having had that transplant. When we look at the latest statistics from the International Society of Heart and Lung Transplantation, who have a registry, you can see that people with CF, the median survival is 9.2 years. Now you have to be careful. That's the median. So that there are people who could die a day after getting a transplant, but there are people who live 20 plus years after getting a transplant as well. So the median survival is where 50% of people are alive after the transplant, and that's 9.2 years, compared to 5 years, basically, for some of the other diagnoses. So people with CF actually do better, but not good enough, right? We're not satisfied with 9.2 years. We want better. So our mission is to improve the care and long-term outcomes of individuals with CF and advanced lung disease by optimizing the decision-making and access to lung transplantation and improving outcomes after lung transplantation. I'm not going to go over this. You guys had to stare at this for about 10 minutes yesterday. But the point is, our focus really is on people with CF, and that's what drives this entire initiative. And that's why it is so organizational-wide and so robust an effort, where we're trying not to leave any stone unturned. We're trying to address every issue we can think of to make the lung transplant journey better. And like I said, hopefully we'll go into a little bit more detail. So we did many things simultaneously, and we formed this lung transplant consortium. We asked for applications, actually. So we sent out a request for applications, and we received 16 applications from transplant programs. There are about 55 or so lung transplant programs in the country. So clearly not everyone felt that they were ready to join us. We made it clear in the application process that we were looking for centers that were ready to be collaborative, that were really ready to be transparent and work together. And we received 16 applications. We funded 10, and you can see on your right-hand side the names of the 10 sites. As you can see, they're all large academic sites that do a lot of CF lung transplant. And then our objectives in bringing this group together was to, first off, reduce the variability in care that is quite obvious from transplant program to transplant program. And where we've been very successful in CF, though not perfect, is reducing that variability in care in CF programs. And it allows you then to actually see what makes one program stand out versus another and lead to better outcomes, and have all ships rise together, right? Everyone floats together higher when we learn what sort of processes lead to better outcomes. And the only way to do that is to reduce that variability in care and then learn and adjust from there. So continue to do your plan, do study, act cycles, and your quality improvement. Benchmark the sites that do well and see what we can learn from them. And in fact, Aaron, I, Joe, and several others that have volunteered to help us have already benchmarked Duke University, and we actually learned quite a bit about their program. We're going to go out to a site that's not part of the collaborative. That's the University of California at San Francisco. And then we're going to go also to Toronto and to Penn. So we're going to go visit 4 different sites. And once we've done that, we're going to share all that information with the consortium sites and see what they can take back to their local realities to help their programs. We're building a shared database, again, so that we can learn from each other and accelerate improvement, just as we've done with the CF Foundation Patient Registry that has led to quality improvement and reduction in variability in care. And then build a shared biorepository. Lung transplant patients undergo lots of procedures, lots of bronchoscopies, lots of biopsies. There's a lot of tissue that could be stored for future study once we're ready to introduce therapeutics, right? Because that's really where we want to get to. We want to build the infrastructure to lead us to where we can find therapies that we can study in people who've had a lung transplant. And lastly, allow for these multi-center studies to occur. And with that, I'm going to pass this over to Erin.
Thanks, Al. Just a quick reminder, if you have questions, you can go to cff.cnf.io, and we'll be happy to answer those when we're finished. So Al did a great job in setting us up where we started and kind of where we're going. So I'm going to dive into a little bit of the meat of what are we actually doing. And one of the first things we did was set up multiple different committees. And the first one is working on developing CF-specific referral guidelines. So their goals are to provide patients and families and care providers guidance on this transplant process, and most specifically the referral process. And we've heard loud and clear that it's frustrating, it's confusing, it's scary. So we want to make sure that we're making this easier on you throughout that process. So we're working on a working group to update ISHLT guidelines, so that's the International Society for Heart and Lung Transplant, based on current criteria and our center's experiences. So they've actually all shared their policies with us, which is fantastic. Our lung transplant programs have been extremely transparent and very willing to collaborate with each other, which is really exciting. So we have 3 different groups within there that are working on specific things. The first one relates to timing for referral and components of the transplant testing in people with CF who are going through the transplant process. We also are looking at modifiable barriers to listing, so things that we potentially have the ability to change if we know about them soon enough, to give people the best possible chance to get to transplant quicker and in a more timely fashion. And then this transition to transplant and consideration of our patient and caregiver perspectives, and we're really excited about this. We actually have a focus group within this committee that is led by a patient who's post-transplant, as well as a psychologist from Duke. And it's about 8 patients and family members, and they've been meeting every other week for the last couple of months, going through their experiences, sharing with us what we can work on, and we're really excited to incorporate that into these guidelines. We kind of take it all back to the community, and the voice of the community is extremely important. So our next steps, they are moving fast ahead with Kathy Ramos from the University of Washington and Jordan Dunitz from Minnesota are leading this, and we're all coming together again in May for a face-to-face in Bethesda where they will vote on the recommendations. Once they vote on the recommendations to be in the guidelines, they will start writing over the summer, and our goal is to have something out for public comment by the end of the year, which is extremely exciting. And the other part of this is developing educational tools and making this applicable in real life. What can care centers use to help them through this process? What can patients and family members use to help guide them through this process? And then the other part of this is our CF Lung Transplant Transition LLC, which is extremely exciting. So our 10 transplant centers all identified one of their top CF referring centers to partner with. We kicked off in October, and we'll be coming together again in DC next week. So up until now, they've been working individually. So the transplant centers have been working on quality improvement work, and the CF centers have been working on it. And our aim here is to improve and decrease practice variations in the systems and processes related to lung transplant. And the other part of this is to help the transition from the CF program to the transplant program, and then ideally to a model of shared responsibility for caring for the person with CF who undergoes a lung transplant. So this shows you we have our referring program and our transplant program with our patient in the middle. And our goal, again, is to get that model of shared responsibility for the care. And once they get together and figure this out, we'll have them spread that to their other CF referring centers, because most of these transplant centers have patients come from multiple different CF programs. Actually, let me back up real quick. Sorry. So they also, over the last few months, have all done site visits. So the transplant team was able to visit the CF center, and the CF center was able to visit the transplant center. And we have received phenomenal feedback on that. They all kind of went into it with their own thoughts about what each other was not necessarily bringing to the table, and they left with a completely different appreciation for what each center was facing. And now they're able to move forward after we get together next week as a combined team, so that kind of transition team. Our next group that we put together is our Advanced Lung Disease Guidelines group. So the goal for this group is to increase the knowledge of the issues that are specific to individuals with advanced CF lung disease and to improve the quality of care for complications. And this is regardless of whether someone chooses to go forward with a lung transplant or not. We want to make it very clear that we are not forcing this on anyone. We just want to make sure people know that it is a treatment option. So they are also broken up into subgroups. The first one is medical management and bridging to lung transplantation in people with CF and advanced lung disease. The second group is looking at management of comorbid conditions, so things like sinus disease and malnutrition, cystic fibrosis-related diabetes, and how do we manage those and optimize this patient on their way to transplant. And then the third one is symptom management and end-of-life planning. And this one involves pain management. We're actually really excited. Some of you or your family members or care team members may have received a survey recently about pain in CF specifically, which is really exciting. It's coming out from Johns Hopkins, and we were able to add transplant-specific questions to that survey. So we're hoping to learn a lot of really great information from them. So their timeline's a little bit longer. We have probably 12 to 18 more months before we have anything ready to bring out for public comment. But they're doing really great work, and we're very excited. The third is CF-specific post-transplant. So the goal of this group is looking at the comprehensive approach post-transplant. So once you have a lung transplant, that does not mean your CF goes away. I wish it was that easy. If you take enzymes before transplant, you're still going to need enzymes after transplant. If you have sinus disease before transplant, you're still going to have sinus disease after transplant. So this group is looking at those specific things that relate to CF. They are kicking off this spring. We are finalizing that working group right now. And again, their timeline is about 18 months. They will look at things also. I forgot to mention, in all of these, mental health is a big part, depression, anxiety, and mental health. So each committee is looking at that as well. And then the last kind of group we put together is the research group, which was split into two. One of them is looking at a clinical database. So what variables do we want to add to our CF patient registry that are specific to transplant? So pre-transplant variables, and then we're also looking at post-transplant variables. And then we also, the second group is looking at basic and translational science. So what samples, blood, sputum, airway, can we collect to use for research? So these two groups are also working, and hopefully we'll have some things to our registry team by the end of the year to get some variables added into our database.
So the research aspect of this actually has been a little bit slower to develop than I had anticipated. We formed all these committees, as Aaron pointed out, and have gotten a lot of guidelines work started. We've gotten the consortium working together. We've actually partnered with UNOS, as I mentioned yesterday, in terms of seriously looking at the lung allocation scores, specifically the variables that are involved in that, and whether or not they accurately predict waitlist mortality for people with CF. But the research part took a little bit longer. It is now really coming into full swing. And I remember just after being at the foundation several months and the research part not really moving as fast as I thought it would. And Preston Campbell walking into my office, and I'm kind of bemoaning this. And Preston just kind of looks at me and goes, "The research is always the last thing to take off." I'm like, wow, okay. But now it has. We funded. When we started, we funded 9 research grants, though they weren't specifically on chronic rejection. There was some chronic rejection and some other aspects of this, and there were smaller research studies. A nice way to get started, but not really the big vision that we had in terms of how do we crack this nut in terms of chronic rejection. So we had a research workshop just a couple of weeks ago, and I was really excited. I learned so much. You can actually have your entire genome studied with a little box that the person who brought it had in his pocket that cost $1,000. It's amazing. Now, he's a microbiologist, so his interest is in the microbiome of the airway. So he only looks at 3% of all that DNA. So there's a whole other 97% of DNA he doesn't even look at, because all he's interested in is bacterial DNA. We learned that there are new ways to look at CT scans that can tell us about chronic rejection and small airway disease. So we learned where there are potential areas to focus on characterizing chronic rejection in a better manner than we have up until now. And to be honest, basically what we have up until now is looking at lung function tests. So we want to expand that. We want to better characterize this, because that will, we believe, lead us to better understanding of chronic rejection, and then hopefully, as I mentioned, therapies. So our research priorities are better characterizing chronic rejection and mitigating its advance. And then, as I mentioned, increasing access to organs, where we're working at looking to see, we don't know if we can find a better mousetrap, if in point in fact we can add anything to the present lung allocation score. But we're going to try, and we're going to see if there are variables that better predict mortality than the ones that are presently used. We've also partnered with them to improve the process to appeal. So when a physician feels the patient is sicker than the lung allocation score would lead you to believe, and they feel they need to be moved up on the list, they can appeal to UNOS. And we are working, and in fact, hopefully we'll have ratified next week at our steering committee meeting, a template that CF transplant programs can use to petition UNOS, hopefully more effectively, to explain why that person really needs to be allocated a higher score. And then, as I mentioned yesterday, we're going to be putting out a public comment in terms of this geographic distribution, and where now the first call does not necessarily go to the person within that donor service area, but rather it goes to the first person who is the sickest within a 250-mile radius of the donor hospital. The question really becomes whether or not 250 miles is appropriate, 500 miles is appropriate. Do we actually need to think about this in a little more nuanced fashion and think about population densities? Because in the Northeast, 250 miles and 500 miles means something very different than it does in the Northwest, right? So we're partnering with folks in policy to do that. And then quickly to wrap up.
Yep. So I'll just wrap up with what are we doing to support you and people along the transplant journey. So you've heard a few times over the last few days, CF Peer Connect. It's fantastic peer mentoring program. There are people there who have gone through the transplant process and are available as mentors. Community Voice, we have used Community Voice. They are amazing. I just want to thank everyone who's a part of Community Voice, because on all of our working groups and committees, we not only have patients but also family members. And the only way we can find them is through Community Voice. So this provides opportunities for people with CF and their families to have an active say. It's extremely important to us. You're the ones that have lived it and are going through it, and we can't do this stuff without you. And then just a plug for the CF Minicon on Transplant August 5th. That will also be open to family members, which I think is really important for this population. And then lastly, Compass. So we've really beefed up Compass with transplant support. We've done specific transplant education for them, and there are listed here a few things that they can do specifically to help. And they go everywhere from assessing insurance coverage and options, helping find financial assistance throughout the experience, connecting with resources for support for people with CF and caregivers, finding educational resources. They have a lot of resources at their fingertips, and transplant centers, where you can go to look up transplant centers, and then identifying academic scholarship opportunities as well. So with that, I will end, and thank you all very much. I think we'll open it up to questions. We have a few up here.
I can go ahead and, can you hear me? Yes? So the first one, is there messaging fundraising events can share with supporters about the initiative and the importance of being organ donors?
I can take that. So yes, we actually have a one-sheet document that is available that kind of gives our big picture of what the initiative is. And I'm not sure, to be honest, where to locate that, but I can find out. And then as far as organ donation goes, yes, we are obviously very supportive of organ donation. It's extremely important. And I will tell you from all the patients that I have taken care of post-transplant, they become very invested in that. It's a very special gift, and we need more organ donors, not just lung, but all organs. So we are supportive of that, and I believe we'll be putting out a policy about organ donation tables at events that will be allowed to have CF staff members man them. So keep an eye out for that.
Yeah, and if I could add, for those of you who have a lung transplant story, I think that's the most powerful message. I know I've heard from one of our families where the lung transplant recipient has gone to schools and shared her story, so high schools. And when you think about demographics and where you may get the greatest return on your investment for trying to get that message out, those are great places. But I think the most important thing is sharing your story out there, not necessarily just having a booth at a fundraising event. I think that's important, but finding venues where you can tell your story, that moves people to go ahead and become donors.
They're coming in fast.
Okay. Which one?
Here, I have a good one. So at what point in lung function decline did the care center team start talking about transplant? So this is a very hot topic. Currently, the number out there that we're trying to get away from is 30%. Quite frankly, that is way too low in most situations to start talking about transplant. So our goal, when we talk about advanced lung disease, that group is looking specifically at the definition of advanced lung disease, but right now all of the work we're doing is surrounding this 40% mark. We really want to bump that up to 40. That's when we start talking about it. And that does not mean at 40% you're going to need a lung transplant. That just means, hey, it could be coming down the road. We want to start talking about it and normalizing it so that if and when it does happen, it's not as scary and it's not out of the blue and you aren't sick or more sick than you currently are. So that is our goal, is to kind of push that threshold up to 40%.
The important part being, it doesn't mean that you're ready for a transplant when your FEV1's 40, and in fact, maybe even when your FEV1's 30. There was a recent paper. So we've settled on an FEV1 of 30 because some 20 years ago, there was a study that indicated that once a person with CF crossed that threshold of an FEV1 of 30, the median life expectancy was 2 years. A recent paper, a current paper, shares that it's about 6 years. So in other words, our ability to care for people with advanced lung disease has improved markedly over 20 years. So it doesn't necessarily mean you need a transplant now, but the important thing is to have these conversations, normalize these conversations so they're not a shock when someone with CF hears about them. And so that's what we're trying to advocate, not necessarily that we're advocating that there's a transplant occurring when your FEV1's 40. And then, is the plan to have the hospitals that are not part of the current consortium follow the recommendations of the consortium? So we're actually building different sets of recommendations, right? So there are the referral recommendations and the advanced lung disease. And those are specifically targeting CF care programs. So that's our audience for those, is to make sure that people are being referred in a timely fashion and not too late. And that's our target audience. There's going to be the post-transplant paper on CF-specific post-transplant related issues. And we hope it's going to be published in a journal that is read by the transplant audience. And we hope that they will read them and take those guidelines. But implementing guidelines is always a bit challenging, as many of you in the audience may know. Even implementing our own CF care guidelines within our CF programs is never 100%. Hopefully the material will be available to them, and hopefully many of them will go ahead and follow those guidelines.
Here's a couple about rejection. So since rejection is a major issue with transplants, is there anything in the works to find a less invasive test for rejection?
That's a great question, because right now the gold test for rejection is a transbronchial biopsy. So you need to have a bronchoscopy and you need to have pieces of your lung taken out with these biopsy forceps. And right now there is nothing else. People have been searching for biomarkers, so in other words, blood tests that could tell you that when X is elevated, that means rejection, but we've not really found a pattern that consistently predicts rejection compared to, could it be infection? Could it be an airway anastomotic problem where the surgeon, so whenever there's a drop in lung function, we think about an entire list of differential diagnosis. And unfortunately right now there isn't a blood test, but that's part of the research. We're hoping to find something that would be less invasive. And then for chronic rejection, it's really, even a transbronchial biopsy is not good enough. If you want histologic proven chronic rejection, you need to do an open lung biopsy. And again, that's part of what our research focus is going to be, is to look at CT scan patterns, blood tests, different types of lung function, maybe the lung clearance index, but we want to see if there are going to be other markers that can predict chronic rejection.
So I think this one may have been answered by that response, but we're familiar with the drug pipeline for CF. What is in the pipeline to improve transplant survival and reduce rejection?
Yeah, again, this is where there's substantial need. The truth is that none of the immunosuppression that's used in lung transplantation is even approved for lung transplantation. It's all been approved for kidney. It's not FDA approved. Pulmonologists use the drugs, obviously, but to get companies interested in looking at therapies for lung transplantation has been challenging. Now, we in the CF world know a thing or two about that, right? So again, we're hoping that we can bring some of our secret sauce to the transplant world. I can tell you that the one new therapy that's out floating around is there's another version of inhaled cyclosporin. I don't know, for those of you who've been in this for quite a while may remember the first go around with inhaled cyclosporin. So cyclosporin is an immunosuppressant that is taken orally, but there is an inhaled formulation. So we may be looking into that as a potential therapeutic study, and maybe one of our first ones. But right now, the pipeline is not anywhere near as robust as the CF pipeline.
Many people who go to transplant don't follow up at a CF center once they are transplanted, therefore losing that registry data. Has there been any discussion how to recapture that patient data so that we stop losing the data? So
absolutely. And so that's part of what we're doing with building a transplant registry and building it within the CF patient registry, because we have so much rich pre-transplant data already that what we want to do is sort of have a seamless flow of that pre-transplant data into the post-transplant data to help us characterize, were there risk factors prior to transplant that led to this complication, so that we can learn. So this is all part of now capturing the post-transplant data within our CF patient registry and having either or, depending on where the patient's being seen at the time, the CF program or the transplant program entering that data. And we are providing support. So those 10 consortium sites receive some funding from us, and that's specifically for a research coordinator to help them manage this data and give us this data.
How effective is matching criteria for lung transplant versus other organ transplantation?
So we don't routinely do a lot of matching. What the matching we do is to look to make sure that the recipient doesn't already have preformed antibodies to antigens, proteins specifically on the donor cells. Because if the recipient is already pre-sensitized, that means their immune system is geared up and just waiting to react to that specific protein on the donor cells. So we try and avoid transplanting a person who has that type of positive cross-match. But other than that, there isn't that HLA matching that you sometimes hear in kidney transplant. And when studies were done on this years ago, there really was no difference in outcome. So it wasn't really worth delays in transplanting a patient to look for HLA matches. So what we look for is really matches, though, specifically against the donor.
I think we have time for one more. Why does it seem so many patients get cancer post-transplant?
So the risk is higher among lung transplant recipients, and in fact, it tends to be higher among people with CF compared to other diagnoses that lead to lung transplantation. Part of it is because lungs reject more frequently and more severely than other solid organs, that lung recipients are on greater amounts of immunosuppression than people who, let's say, receive a liver transplant. People who are on a liver transplant might only be on one immunosuppression. There are, in fact, now some people who've received liver transplants that don't take any immunosuppression. Lungs, we're not that lucky. Lungs, lifelong therapy is 3 immunosuppressants. And when you're immunosuppressed, that increases your chance of developing cancer because your body really has developed this immune surveillance system to recognize cancer cells early and get rid of them. But when you suppress someone's immune system, you sort of curtail that ability. And we also think that the reason people with CF are more vulnerable are because people with CF are younger. And so we see more of this, what's called post-transplant lymphoproliferative disorder, which is a spectrum, but it's a spectrum that can lead to cancer. Other cancers, in fact, the more common cancers for transplant recipients include skin cancers, but they are at increased risk for all cancers.
And then we have 1 minute left, so I will address this one last one. We've seen a number of families have to travel out of state for a lung transplant. Will this be addressed under the initiative? So part of this is due to insurance, and that's going to dictate where the patient needs to go for a transplant. Part of this may be due to the fact that a patient might have some sort of bacteria that one center isn't going to transplant, another center might transplant that. So we're trying to learn from those centers that do accept patients from out of state, what they do to help support those families. And for example, when we went to Duke, they have all patients relocate before they're listed, and they go through a very intense, I think 28-day rehab program before they're able to list them. So majority of those patients are relocating. So again, we're trying to learn from those centers how they do that and how we can help along that process. So with that, thank you all very much, and have a great rest of your day.